Good morning, everyone. My name is Dana Bowen, and today we are starting our grand rounds. It's my pleasure to introduce our grand round speaker, Dr. David Allen Bushinsky. Dr. Bushinsky completed his medical degree at Tufts University School of Medicine. Then he stayed on at Tufts New England Medical Center to complete his residency and fellowship in nephrology. He currently serves as professor of medicine, professor of pharmacology and physiology, and the chief of the nephrology division at the University of Rochester Medical Center in New York. Much of his 40-year career has been dedicated to understanding calcium homeostasis at the level of the kidney through NIH-funded research. He has published several hundred journal articles and book chapters on this topic and continues to be involved in a large number of clinical trials. His most recent work in developing a new treatment for metabolic acidosis in patients with chronic kidney disease looks to finding therapies that can improve bone mineral density in older patients. Dr. Bushinsky has received honors from the American Society for Clinical Investigation and the Association of American Physicians. He continues to dedicate his career to advances in nephrology through medical education and in his board positions at the Renal Research Institute and the American Society for Clinical Investigation, to name a few. Thank you, Dr. Bushinsky, for joining us this morning.
Dana, thank you for this lovely introduction. It's a pleasure to speak at Rutgers because I grew up about 10 miles away from where you're sitting right now in Linden and spent my entire childhood right there in New Jersey. So today we're going to talk about kidney stones and bones. And as Dana said, I'm at the University of Rochester, which is in upstate New York. So let's start out not with grand rounds, which usually often starts with a single patient. Let's start with about 1,000 patients. If these are patients who are referred to a kidney stone clinic, about 750 men, 250 women. They're about 34, 35 years old, and they've each formed about 1 stone per year. So 100 stones per 100 patient years, or 1 stone a year, and each patient has formed 6, 8 stones. This is devastating to the patients. It totally interferes with their life, their incredible stories of missing birthdays, of not giving a concert for a concert pianist, of not participating in family events, of being afraid to travel because they were worried about a kidney stone. It's also led to incredible morbidity, cystoscopies, hospitalizations, infections, surgery. None of these patients died, but they've suffered from their kidney stones. And over the next 45 minutes or so, we're going to see how we can help these patients. So as you all know, kidney stones often present to severe flank pain that radiates to the groin. That said, kidney stones present in many different ways, from diarrhea to gastric upset. If you suspect a kidney stone, it's not hard to figure out if your patient has a kidney stone. The annual incidence, 7 to 21 cases per 10,000. We'll talk more about the prevalence. Males, a bit higher than females. A number of hospital admissions, oftentimes not to medicine, but to urology, though these patients oftentimes present to the primary care provider. What's interesting is higher BMIs are associated with more kidney stones, and it's a linear association shown in a number of studies. So let's go think about the prevalence a little bit. This is NHANES data. In 1980, the males are on the left, the females in the center bar, and you can see that the prevalence increased from 1980 to 1984, both in the males and females, to 2010, and about the same, little more in the females in 2014. This marked increase, a doubling over 25, 35 years, is certainly not due to genetics. It's too fast for that. It means that something that these patients are doing, their lifestyle, their diet, their fluid consumption, is leading to more kidney stones. But what it's also telling us is that there's a therapeutic window here, that we can return patients from this prevalence, not this individual patient, but other patients back here if we treat them properly. Let's look a little further at the prevalence. If we look at age 20 to 39, the females actually have a little higher prevalence than the males. The males take over as we get a little older and markedly increase in later ages. But overall, we think a slight male predominance, maybe 11 to 9, but it's the more studies that we do, the females are catching up. So let's think about the type and frequency of kidney stones. These are 1,700 consecutive stones that we saw in clinic, and more than a third are calcium oxalate and calcium phosphate. About a quarter are calcium oxalate alone. 7 are calcium phosphate alone. Uric acid stones, which are a radiolucent stone that we see about 1 out of 20 stone formers, are not due to an increased uric acid excretion, but in fact due to lower urinary pH. This is a favorite board question that I've written myself. Lower urine pH induces uric acid stones. Cysteine is an inborn error of metabolism that you probably, if you see it, probably should refer this patient because it's very difficult to take care of cysteine stones. And struvite stones, infection stones, can be devastating because they're big horseshoe stones and they can obstruct ureters and cause incredible inflammation, infection, and death. But today we're going to talk about calcium-containing kidney stones, which are the majority of kidney stones and the stones you're most likely to see in practice. So what disorders are associated with these calcium-containing kidney stones? Again, 1,650 consecutive patients. Surprisingly, primary hyperparathyroidism picked up in 7% of these patients. Excess PTH, people simply don't look for it. You should look for it because, 1 out of every 12, 15 patients are going to have primary hyperparathyroidism, and obviously it's easily corrected surgically. Idiopathic hypercalciuria, excess urine calcium of unclear etiology, is fully a third of the patients. Although we don't know what's causing the excess urine calcium excretion and subsequently the kidney stone, we can correct it. Excess uric acid excretion, a quarter of the patients. Renal tubular acidosis, specifically distal renal tubular acidosis with low serum bicarbonate and low potassium, a few percent of the stones, and very important to make that diagnosis. Excess oxalate excretion, 5% of the stones, and truly idiopathic. We don't know why this patient's forming a kidney stone in a third of the patients, but again, just like in idiopathic hypercalciuria, there are effective treatments, and I'll show you the data in a bit. Idiopathic hypercalciuria, which we said is the most common risk factor for kidney stones, is clearly a genetic abnormality. How do we know this? Well, it's more common in relatives of calcium stone formers than relatives of non-stone formers. Relatives of calcium stone formers have exaggerated urine calcium excretion response to giving them some oral calcium. And perhaps the best data is the familial occurrence of hypercalciuria in the twin studies, especially in the twins who are raised apart. So it's not diet or fluid consumption or geography. These twins were raised apart, but in fact, both twins have an increased incidence of kidney stones. To understand kidney stones, you have to understand urinary saturation. This will take you back to high school calcium. High school chemistry, An undersaturated urine is one in which the components of the stones, such as calcium and oxalate, are so far apart that they'll never come together and form a solid phase. At the equilibrium solubility product, these ions, such as calcium and oxalate, are in equilibrium with the solid phase. In a metastable urine, the calcium and oxalate will form on a nidus, such as cellular debris or another crystal. It's a metastable solution. At the formation product, the calcium and oxalate are so close together that statistically they will come together and form a kidney stone. And an unstable saturation, urinary saturation, we really don't see, but that's when everything just precipitates quickly. So as we go from undersaturated towards metastable and towards unstable, we're getting increasing saturation. And that leads to increasing probability for stone formation. The key to therapy, as we'll discuss, is moving this saturated urine into an undersaturated urine so that the kidney stone cannot form. So let's understand calcium homeostasis to understand kidney stones. I put things in terms of millimoles. That's how the rest of the world works. And as you know, there's 40 milligrams per millimole of calcium. So we normally take in about 800 milligrams of calcium, excrete about 80% of it, and absorb about 160 millimoles of calcium. Goes into very small extracellular space. On a daily basis, there's bone formation and bone resorption in non-pregnant, non-osteoporotic, non-growing adults, and they're absolutely equal. The largest repository of calcium in the body, of course, is in the bone. Our kidneys filter calcium. They reabsorb the vast majority of what's filtered, and we only excrete as much calcium as we absorb. Beauties of integrative physiology: urinary calcium excretion equals intestinal calcium absorption for most of us. So because of that physiology, I and colleagues struggled for years to try to determine why there was excess urine calcium excretion. And we studied increased intestinal calcium absorption, either direct or through excess activated vitamin D. We studied decreased renal mineral reabsorption of calcium and phosphorus. We studied enhanced bone demineralization and came to the realization that while these were intellectually interesting, in reality, there is not one specific mechanism. Why do I say that? This is a study done by Amy Liswitz-Strauss a while ago, and what Amy found was that if she took normals and patients with idiopathic hypercalciuria and put them on a low calcium diet, every line is a patient, every dot is an observation, and most of the patients complied except for one, and looked at urine calcium excretion, the normals went up, the patients were higher, as you might imagine, because these patients had idiopathic hypercalciuria. But then she looked at calcium balance. What did she find? Normals were in positive balance, but the patients ranged from positive balance to negative balance. Positive balance meaning they were retaining calcium, negative balance meaning they were excreting calcium, more calcium than they were absorbing. But it was a smooth line. The patients didn't segregate into clumps, into groups that you would imagine if there were specific etiologies for the hypercalciuria. And the most interesting thing is on some days a patient was in positive balance, and in other days the patient was in negative balance. What does it tell us? It tells us that there's no specific one etiology for hypercalciuria. It also tells us that if you take a patient, such as anyone down here, and put them on a low calcium diet, which for years was a recommended therapy for patients with kidney stones, they would be in negative calcium balance, their bones would be depleted of calcium, and you would have a worse problem of osteoporosis and fracture. So what we learned from this graph, from this slide, is don't try to divide the patients into groups. And this is the first time that I'm going to tell you something that I will repeat over and over again. Don't place anyone with kidney stones on a low calcium diet. So how do humans form kidney stones? Well, the first observations really were back in 1937 by Randall. And Randall found that this is the urinary space and this is the papilla of the kidney. And Randall, in autopsy studies, in several papers in 1937, demonstrated plaques on this urinary space that were eroding through the tissue into the urine. These were called Randall's plaques, and everyone promptly forgot about this seminal observation. For years, everyone thought kidney stones formed because a crystal got caught in a tubule. Makes sense. Well, then someone, Birdwell Finlayson, years ago, figured out that the urine flow is simply too fast for the crystal to form. Okay? So others suggested that there were charges on the crystal that interacted with charges on the cell wall that slowed the flow enough that the crystal would form. And that's where we were until Andy Evan did was just a gorgeous study. He and Jim Lingeman actually took biopsies of this area of kidney stone formers. And what they found was the first crystallization was actually within the tissue, A here, and it was a calcium phosphate. It would grow and expand and erode into the urinary space, forming a Randall's plaque. And this calcium phosphate formed the nidus for a calcium oxalate kidney stone, right? The most common kidney stone, calcium oxalate, to form. And this stone would just grow and grow and grow. And when it finally broke off, it would obstruct the ureter, cause severe pain, and we'd have a clinical kidney stone. What it also taught us, though, is if we can prevent this calcium oxalate overgrowth, even if there's a Randall's plaque with calcium phosphate, your patient won't have a clinically significant kidney stone. They might have some calcifications at the papilla, but they're inconsequential. If you can lower the urinary supersaturation, prevent this calcium oxalate overgrowth, you can prevent a recurrent kidney stone. So I said we're going to talk about stones and bones. Well, what about bone? On this slide, which purposely is impossible for you to discern the individual studies, you see a predominance of downward arrows. And that's bone mineral density at the spine, the hip, and the radius. And there's clearly a reduction in bone mineral density in human kidney stone formers. In fact, when Sakai put this all together, he found that the percentage of patients with decreased bone mineral density at the spine was 40%, the hip 31%, and the radius 65%. So kidney stone formers have low bone mineral density in various sites, but especially the radius. So does this result in fractures? Now, this is hard to study because kidney stones recur maybe in 5 years. About 50% of patients will form a second kidney stone. And bone mineral density also takes a long time to change. So the first studies were actually done by Melton, and this was in Rochester, Minnesota, Mayo Clinic, Olmsted County. People kind of stay there. So they just followed the patients, kidney stone formers, and this was the expected number of fractures. The observed number of fractures was far higher. So they made the observation years ago that kidney stone formers tended to have more fractures. More recently, Eric Taylor looked at the NHS study in women and the health professionals follow-up studies in men, and in both cases found an increased risk of incident wrist fractures in those that formed kidney stones compared to those that didn't. About a 20% increase overall. So wrist fractures, remember that was the site of the greatest reduction in bone mineral density. Eric didn't find any change with hip fractures, but it seems that our patients with kidney stones have not only decreased bone mineral density, but increased incidence of fractures. More recently, Michelle Denberg looked at both males and females, a large number of stone formers and controls, and found that, especially in the females, there was an increased incidence of fractures at every age group in stone formers compared to non-stone formers. All of these points are significant, except for this one for the males, because we're dealing with such large numbers. So there's clearly an association of increased fractures with kidney stones. So now we have a problem. We're trying to study hypercalciuria. We're trying to study kidney stone formation. We're trying to study their bones. And we have two disorders, osteoporosis and fractures, and kidney stones that take a long time to have a second episode for kidney stones or to have a fracture with respect to bone. And it would take hundreds of thousands of patients studied for years to really find associations and even cause and effect. So we developed an animal model called the genetic hypercalciuric stone-forming rats. I'll spend a little bit of time on these rats because they mirror human physiology perfectly. First of all, how did we do this? We screened a large number of typical male and female Sprague Dawley rats, found the ones with the greatest urine calcium excretion, and bred them. And we just kept doing this. We're now up to about 135 generation, but you can see that the urine calcium excretion truly went up dramatically, tenfold compared to the baseline Sprague Dawley rat, which hasn't changed over these years. And not to get too much physiology, but the rat's intestine absorbs far more calcium, the GHS rat intestine, than the control, both the males and the females. And if we present the kidney with a constant filtered load of calcium and take away parathyroid hormone, they also excrete excess urine calcium. So these rats have increased urine calcium excretion. That's what they were bred for. They don't reabsorb calcium as well as they should, and they absorb excess amounts of calcium. This is leading us to think that this hypercalciuria in the rats and in humans is not due to one specific abnormality, but is due to a systemic dysregulation of calcium transport at calcium transporting sites. More about that later. So do the rats form stones? Absolutely. By 18 weeks, 100% of the rats form kidney stones, none of the controls. If we add the amino acid hydroxyproline to their diet, these rats form calcium oxalate stones. If we don't, they form calcium phosphate stones. So it's a good model because we can adjust the stone type. And this is, in fact, a calcium oxalate kidney stone, indistinguishable from a human calcium oxalate kidney stone from a hypercalciuric rat. So we talked about their stones. Let's talk about their bones. Well, like humans, The GHS rats have a lower bone mineral density in the tibia and literally every other site compared to the normal Sprague Dawley rats. Little bone physiology, the osteoclasts, which are the cells that resorb bone, are bigger and more numerous in the hypercalciuric rat than in the control rat. The quantitation here, the area is greater, the number is greater. And the bone-forming cells, the osteoblasts in the GHS rats, don't make as much bone than the normal Sprague Dawley rats. So not only do these rats have an abnormal intestine and kidney, they have an abnormal bone. Their bone resorbs too much calcium. It doesn't form calcium as well as it should, resulting in a decreased bone mineral density. So this physiology is also exactly what we see in humans. While an animal model is never perfect, this physiology appears to mirror that of human stone formers. Last bit of physiology, because it applies to people. GHS rats have increased receptors for activated vitamin D on the bone, in their kidney, and their intestine, and the studies to date show that humans have the same thing. We might find in not too distant future that idiopathic hypercalciuria may well be due to an excess vitamin D receptor, which is biologically active in humans as well as our rats. So most of you don't take care of rats. Most of you take care of people. So let's spend most of the rest of our time talking about how we evaluate stone formers. The first question that people ask when they come into our kidney stone clinic is they say, "Doc, I'm 35 years old. I've never formed a kidney stone before in my life. Why should I bother doing anything? If I go another 35 years and not form another kidney stone, I'm good." Well, we tell them the data suggests you'll form a kidney stone a bit sooner. There's 5 studies in which the patients were observed to form a kidney stone and absolutely nothing was done or suggested to them. British Navy, Rochester, Minnesota, Leeds, Norway, and San Francisco. And what you can see is there's a bit of variation. In Norway, they form stones a little more rapidly than in Rochester, Minnesota. But what we tend to tell patients is that after about 5 years, about half of you will form another kidney stone. And if you do something, and it's not very difficult to prevent that next stone, you can clearly delay or eliminate a recurrent kidney stone. So what should we do? We think that every patient with a kidney stone should undergo a very basic evaluation. And this isn't just me, this is every group that's really looked at it. Basic evaluation is mostly history. Take a very careful stone history. What's their past medical history? Do they have things like inflammatory bowel disease that might predispose to kidney stones and dehydration? What are their medications? Are they on things like Topamax to prevent migraines, which are carbonic anhydrase inhibitor? They alkalinize the urine, and they predispose to calcium phosphate kidney stones. What are they taking over the counter? You'd be amazed how much vitamin D people can get over the counter. What's their family history? Remember, this is a genetic disease. What's their lifestyle, their occupation? For example, surgeons, airline pilots don't want to urinate because it sort of complicates their job. So they don't drink much water. They have an increased incidence of kidney stones. I saw a sailboat racer who, he's surrounded by water, but he wouldn't drink any because it interferes with the sailboat race. He formed a lot of kidney stones. What's their diet? Do they drink a lot of fluids? Physical exam, unless they're actively forming a stone, is usually not as important as their history. Lab data. If they pass a kidney stone and bring it in, or you ask them to bring one in if they've passed another one, get it analyzed, very inexpensive. Of course, a urinalysis culture, given the high incidence of hyperparathyroidism, we check a PTH in virtually everyone who comes into kidney stone clinic. And it's amazing, sometimes, I saw a guy a few weeks ago pass 7 stones and no one bothered to check his PTH. We check vitamin D, TSH, radiology. We don't routinely get x-rays when someone has passed a kidney stone. But if you want to get an x-ray, think very carefully about simply doing an ultrasound. The gold standard for recent years for kidney stones is a CT scan. And there's no question it's very sensitive, it's very specific, but there's a lot of radiation exposure. And I regularly see young people who have had CT scans after CT scans after CT scans. And this radiation can't be doing good things for these people who want to reproduce. So we try to stay away from CT scans. We concentrate on ultrasounds, quite sensitive, not very specific, but the data clearly shows that you don't miss anything important. If you start out with an ultrasound instead of a CT in someone that you're suspecting of a stone, you won't miss any important diagnoses. New England Journal of Medicine paper about 2 years ago, and the radiation exposure obviously is far lower. KUBs are not that sensitive. Specificity is pretty good, but you're still getting radiation. An MRI would be perfect, but we can't afford that. So we concentrate on ultrasounds, rarely miss anything, and really never miss anything that's important. So that's the basic evaluation. Who should get a complete evaluation? People who have kidney stones that grow in size or number, all the kids, and people with unusual kidney stones, i.e. those that are not calcium oxalate, undergo a complete evaluation, which is basically that basic evaluation plus a 24-hour urine. Now, the 24-hour urine must be done properly, and you must get supersaturation analysis. All of these parameters have to be measured. They can be measured on one urine if it's done in the proper laboratory. I have yet to see a typical hospital laboratory, including our big university laboratory, that can measure all of these parameters on one urine and calculate supersaturation. Luckily, there are some national labs, LabCorp, one of them, and they have Litholink. Mayo Clinic is another one. We'll measure all of these parameters and use this equal to equation to calculate supersaturation, which is the driving force to form that kidney stone. It's what causes the ions to come together and form the solid phase. And you have the supersaturation for calcium oxalate, calcium phosphate, and uric acid. I have no vested interest in you using one of these laboratories. We happen to use LabCorp, but there are others. And if you try to send it to your typical hospital lab, including ours, they'll want to collect 2 or 3 urines, and they'll send the oxalate out to Southern California to be measured. And they don't know how to calculate supersaturation. So think about using one of the national labs that do this for a living and do it well. So how do we treat? I've told you, we reduce urinary concentrations of the substances forming the some crystals. We reduce supersaturation. So the principal abnormalities that we see are people have small urine volumes. Basically, they don't drink enough. The surgeons, the sailboat racer, the airline pilots, all these people have to do is drink more water, the most cost-effective therapy in medicine. Some people, especially some vegetarians and vegans, have high urinary oxalate. because oxalate is an end product of metabolism. Plants store it in their leaves, and spinach, for example, and rhubarb, very high in oxalate. High urine calcium, we talked about it, idiopathic hypercalciuria. We'll talk about treatments for that, which are thiazide diuretics and potassium citrate. High uric acid, I just saw one of our residents who never met pepperoni pizza he didn't like, and his uric acid is sky high. He just has to back off. Low citrate, people who weigh too much, develop the metabolic syndrome, are eating too much protein, lower the citrate excretion. Citrate binds calcium. If your citrate is low, the calcium will bind oxalate. Not so good. Low potassium, this is usually goes right along with the metabolic syndrome folks. They're not eating enough fruits and vegetables. And magnesium is simply an inhibitor of crystallization. So what do we tell people for general treatment to prevent calcium stone recurrence? Keep your urine output high, 2 liters a day or more. We give them a 2-liter jug and tell them that they have to fill this jug every day. Incredibly cost effective. People should have an age and gender appropriate amount of calcium in their diet, which is always about 1 gram. If you have too little calcium, one, you can demineralize your bone and get osteoporosis with too little calcium. You also absorb too much oxalate because the calcium doesn't bind the oxalate in the intestine. Too much calcium, you just absorb some of it and you excrete more of it. So about 1 gram a day of calcium. Sodium, there's 15 recommendations in the literature of how much sodium someone should have. We tell people less than 2 grams, 1.5 grams if they can, but less salt. And moderate the protein, because protein, especially animal protein, leads to metabolic acidosis. You excrete an acid urine, and that's a high calcium urine. What's the data for all of this? Let me show you. Role of fluid intake. This is a beautiful study by Lans Borghi. Lans is an investigator in Parma, Italy. And Parma, where Parmesan cheese comes from, is this lovely town in Italy that essentially no one leaves. You grow up there, you stay there. And important for these studies, these patients listen to their doctors. So what Lans Borghi did was take patients who formed kidney stones, the clear bars, compared to patients other subjects who didn't form kidney stones. And what he found was urine excretion in the stone formers was lower than the non-stone formers. Then he took these patients, the clear bars, and told half of them to drink more water, and the other half, he didn't suggest they drink more water. That's all he did. But the beauty is, Lans studied these people for 5 years. And group 1, the people who drank more water, formed far fewer kidney stones and had a higher urine volume than the people who didn't drink more water, who had a lower urine volume. Simply drinking more water prevented lots of kidney stones. It makes sense. You're diluting the urine, you're lowering the supersaturation, the calcium and oxalate can't come together. Most cost-effective therapy in medicine. 5-year study, brilliant. What about calcium? Let's stick with Lans. In the New England Journal, he published on 120 patients that he randomized to a low calcium diet, which was at the time a suggested therapy. And he compared it to this therapy which we're recommending now, normal calcium, low protein, low salt diet. It's not a specific test of normal calcium against low calcium because we also have low protein and low salt. It's a test of conventional therapy, low calcium diet, with more appropriate therapy, which is normal calcium, low protein, low salt diet. What happened? Again, no one leaves Parma. 5-year study, essentially no one dropped out. The people on a low calcium diet formed far more kidney stones than people on a normal calcium, low protein, low salt diet. This is modern therapy for kidney stone formers. Cumulative incidence of recurrence, much higher on a low calcium diet. If you learn one other thing this morning, the first was not to try to separate the patients into those that absorb too much calcium and those that excrete too much calcium. Don't try to separate the patients. The second thing you should take away from this is that a low calcium diet in stone formers will lead to more stones. It makes sense, less stones, right? You're eating less calcium, you'll excrete less calcium, you'll form fewer stones. But it's absolutely wrong, because what happens is if you have a low calcium diet, you absorb more oxalate because the calcium can't bind the oxalate in the intestine. You absorb more oxalate, you form more kidney stones. Avoid low calcium diet. You'll still see this written about in the popular press, and it is just wrong. What about sodium? This is an easy one. Patients on lower sodium diet, given more sodium, they excrete more calcium. It's simple renal physiology. Sodium excretion will lead to more calcium excretion. What about protein? This is Jack Lemon's work. If you give people more protein, urine calcium excretion goes up, especially animal protein. If you give them base, urine calcium excretion goes down. And this is due to the effect of the acid, the metabolic acid, excuse me, on the renal tubule. It causes more calcium excretion. So, we've talked about general treatment. Suppose your patient still has a high urine supersaturation, is still forming kidney stones. There's really two therapies, thiazides and potassium citrate. Let's talk about them. This is Sakai's work, and both of these therapies not only cause increased renal calcium reabsorption, so you're excreting less urine calcium, but they help promote bone formation. Thiazides. This is a lovely slide by Fred Coe, done years ago. These are patients before they came to his kidney stone clinic. Again, every line is a patient, every symbol is a stone. He put them on thiazides. They formed far fewer stones. But there are better studies. There's actually 5 double-blind placebo-controlled studies. And in every single study of more than 2 years duration, a thiazide diuretic reduces stone formation. We use chlorthalidone because it's long-acting, but hydrochlorothiazide works as well. Meta-analysis, clearly thiazide reduces recurrent stone formation. This is saying about 50%. Also, thiazides help bone. Recurrent hip fractures are reduced with thiazides by about 24%. Why don't we use thiazides to treat osteoporosis? I suspect pharmaceutical companies can't make any money selling thiazides because it's generic and it costs pennies a day. So it's not been really studied. These are observational studies, mostly on people with hypertension, but clearly decreased risk of hip fractures. What about potassium citrate? Same thing. Potassium citrate reduces stone formation. Potassium citrate also markedly improves bone. This is a study of non-stone formers given potassium citrate or placebo, non-osteoporotic men and women greater than 65, given calcium and vitamin D. K-citrate, potassium citrate base to neutralize endogenous acid led to increased bone mineral density in the spine, in the femoral neck, in the total hip, and in the total body compared to placebo. Double-blind, placebo-controlled study of 2 years duration. Brilliant, brilliant work showing that a base improves bone mineral density. Again, why don't we use this to treat osteoporosis? Again, pharmaceutical companies can't make any money selling potassium citrate. So now we have a problem. We have 2 therapies that work well to prevent stones. How about the therapies together? Well, for this, we have to use our hypercalciuric rats because there are essentially no human studies where we put them together. So let's briefly, in the last few minutes, talk about treating calcium phosphate stones. We fed the rats either potassium chloride as a control or potassium citrate, i.e. we want the same amount of potassium in all 4 groups. We gave some chlorthalidone and some the combination. Analyzed the urine 6 weeks, 12 weeks, and 18 weeks, and then analyzed the kidneys, the bones, and the serum. And basically, I'll just show you this. Potassium citrate lowered urine calcium excretion. Chlorthalidone lowered urine calcium excretion in the red, and the combination lowered it even further, suggesting that this therapy may well be really good. However, supersaturation wasn't that clean because the alkalinization of the potassium citrate actually raised the calcium phosphate supersaturation. But stone formation was dramatic. Potassium citrate, in this case, calcium phosphate stones did nothing, where chlorthalidone absolutely eliminated stone formation, and the combination wasn't as good as chlorthalidone alone. So what about the bone? Again, chlorthalidone raised bone mineral density, and the combination didn't raise it further. So this suggests that for calcium phosphate stones, if these rat studies can be applied to humans, and obviously human studies would need to be done before we did this in patients, the optimal treatment is simply chlorthalidone, not the combination. This is for calcium phosphate stones. What about calcium oxalate stones? Well, here we give the rats little hydroxyproline, and they form calcium oxalate kidney stones. And the supersaturation, just go to the heart of the matter here, stone formation was reduced most with the combination of potassium citrate and chlorthalidone, greater than any of the other therapies. Bone was again best with chlorthalidone alone. Potassium citrate, this is bone volume to total volume, was actually a little worse than chlorthalidone. So here, if we give rats a diet that promotes calcium oxalate stones, here the combination of potassium citrate and chlorthalidone prevented stone formation better than either, but bones were again chlorthalidone alone, but the combination didn't hurt. So, for calcium phosphate stones, chlorthalidone alone is superior to potassium citrate alone, or in combination with chlorthalidone, in reducing stone formation and improving bone quality. Calcium phosphate stones. Calcium oxalate stones, potassium citrate and chlorthalidone prevented stone formation better than either agent alone. Again, if we can apply these rodent studies to people, if you have a really difficult stone former who continues to form stones, the combination is better than either agent alone, and chlorthalidone alone improved bone quality. K-citrate didn't provide any additional benefit, but it didn't hurt. So let's get back to our patients. We have these patients who are devastated by stone disease. They're forming a stone a year, and they're miserable. we applied the treatments that we simply talked about over the last 45 minutes or so. We studied them for another 3.5 years, or 3.2 years. Their stones per 100 patient years went down from 94 to about 8, both in the men and the women, and about 89% of both groups didn't form another stone. There's happy patients. It's one of the most gratifying things I can do as a nephrologist is see these stone patients because they're no longer afraid to live their life and no longer fearing the recurrent stone. So let me just thank everybody that I've had a chance to work with over the years, especially Nancy Krieger, who did a lot of the bone biology studies. But it's an international cast of superb investigators. And with that, I thank you, and I think we have a few minutes for questions.
Dr. Bushinsky, thank you so much for this really wonderful presentation and real deep discussion about this interplay between these kidney stone formation and the bones and the gut also, in terms of how that all relates to each other. Really interesting. So let me just encourage people, if they want to ask a question, I think we can do raise hand function or put your question in the chat, and we'll get to that through there. While we're waiting, just the mechanism for the thiazide diuretics, how does that, I'm not sure if I missed that, but how is that working?
So there's actually a thiazide receptor in the kidney tubule, and the diuretic actually occupies the receptor, and it enhances renal tubular calcium reabsorption. How it works on the bone is not clear, but it might simply be as you have more systemic calcium, you encourage more bone formation. But a thiazide is a very powerful agent for kidney stones, and I have to say, especially in our older folks, thiazide is great for hypertension. And again, chlorthalidone, a longer-acting thiazide, is a great agent for older people with hypertension. And by the way, it helps their bone. So it's something to think about in hypertension clinic or in general medicine clinic. Good
yeah, no,
question.
that's a great comment. And just as you said, as the population ages also for hypertension, really way to get at a couple of things at the same time. Let me encourage people again to either put the message in the chat or a raise hand function. Maybe while we're still doing that, and one of the things you showed early on was this difference in between men and women by age, and it was interesting. It's an interesting demographic, certainly in the older population where it seems to be significantly more in men than women.
Right.
Anything about that we could understand?
So, that's a great question, because it's interesting that the women have more stones when they're younger, because we tend to think of kidney stones as predominantly men, but it turns out the women tend to have stones. And I think some of that might be due to early on urinary tract infections and urologic disease. Clearly, we've actually tried to look at the sex hormones on kidney stone formation, and that's been a real dead end. So I don't know why, other than things like women tend to have more struvite stones as they get older because of urinary tract infections. But no one's really studied why men have more stones overall than women. But as we're studying this more carefully, the difference, which used to be 3 to 1, then 2 to 1, now it's about 1.2 to 1, kind of, I think we're all equalizing, both the men and the women. So there's a question in the chat box. Pathogen stones, would you check this in patients with a normal serum calcium? So that's a great question. What's cost effective? Certainly when we're in a kidney stone clinic where the patients have formed 6 or 8 stones, it's almost routine. As a matter of fact, I have to say it's routine. I check it before the patients come into clinic. But how about in your practice? There's clear data to show that primary hyperparathyroidism can certainly be present in patients with a high normal serum calcium and in low normal serum phosphorus. Remember, PTH is phosphaturic. It aids phosphorus excretion and causes tubule reabsorption of calcium. So PTH will raise serum calcium because of increased tubule reabsorption and decrease urinary phosphate. So I check it in normal patients who have any sort of elevation in serum calcium, because remember, we're not measuring the biologically active ionized calcium. We're measuring total calcium. Only about 45% of that is biologically active ionized calcium. So I sort of check PTH more than I suspect a medical economist would think cost effective. But I've been surprised. I diagnosed primary hyperparathyroidism in an orthopedic surgeon who had about 6 stones and was followed by lots of good docs. And no one bothered to check his PTH because the calcium was just a little high, but not really extremely high. Sounds good, but it's a good question.
Thank you. Other questions?
Don't be shy. I suspect there's about 10% of you in the audience who have formed a kidney stone. So, it's relevant to all of it. So what dose of chlorthalidone? We start with 25 milligrams. In some people, 12.5 is sufficient. Low dose. Remember, chlorthalidone will cause a lot of potassium wasting, so you have to be careful. But you start a low dose and check the supersaturation. Prevention of struvite stones, they're not often found until they're very large. Absolutely. Urologists call struvite stones stone cancer. You want to prevent recurrent infections, which is what leads to struvite stones. And then you want to send your patient to a urologist who will remove the entire stone. Because one, if there's a bit of stone remaining, the bacteria that split urea that induced the struvite stone will remain, and the stone's just going to come back. In elderly patients who can't undergo surgery, we do chronic antibiotic suppression, and we change the antibiotic every month or two. And I have several patients that we've gone on years like this. There's somebody, I'm losing it. The role of
we'll do one more. We'll do one last question. I guess it's, what's the role of urinary magnesium in stone formation?
Excellent. Yeah. So magnesium actually is an inhibitor of stone formation. The magnesium is probably binding with the oxalate and forming a relatively soluble compound and competing with the calcium. But magnesium certainly, people should have adequate magnesium in their diet, and most of us do. We've not had to replete magnesium in anyone that I can think of. That said, we often don't check magnesium, and perhaps we should.
Great comment, thank you. Well, I'm sorry, our time is up for this morning. I want to thank you, Dr. Bushinsky, for really a fascinating discussion and real clinical insights into this whole problem of the stone formation. And so really appreciated that. I think that the audience really enjoyed it very much. And want to thank everybody for joining this morning and wish everybody a great rest of the day. Thanks again, Dr. Bushinsky.
Well, thank you so much. It's a pleasure to return to my New Jersey roots. Thanks so much. Bye-bye.
Be well.